Hello, I'm Ben Taylor. I'm one of the heart surgeons here at Saint Alphonsus. If you've gotten to this video, you're going to have questions about persistent atrial fibrillation. I'm here to talk to you about surgery for atrial fibrillation here at Saint Alphonsus. In particular, a procedure called the hybrid maze procedure. Everybody's atrial fibrillation story is different. It's individualistic, so not everything works for everybody, and the pathophysiology is different in each different person. The main treatments for atrial fibrillation are medication, catheter ablation, and then surgical ablation. Surgery for atrial fibrillation may be for you if you're less than 75, you have long-standing persistent atrial fibrillation, or paroxysmal atrial fibrillation that is not well treated with medications or catheter ablation. And especially if you have severe symptoms from your atrial fibrillation like fatigue, shortness of breath, lack of energy, which is interfering with your daily activities and the lifestyle you wish to have. So surgery for atrial fibrillation used to be a big open heart procedure and was pretty complicated, and it was developed in the 1980s. Lately, using minimally invasive surgical techniques, people have figured out a way to do the same fundamentals of that original surgery using a camera and little instruments and radiofrequency ablation technology. Radiofrequency ablation is really just a heat source that burns thin lines in the tissue, and I'll explain why that works with atrial fibrillation. So what I've drawn here is our 4-chamber heart, just a schematic version. Okay, your upper chambers are the atria, your lower chambers are the ventricle. All right, this little pocket that's hanging off here is called the left atrial appendage, and I'll get to that a little bit later, but that becomes important with atrial fibrillation. The heart is a pump, so it's actually 2 pumps in sequence. One is the right side and one is the left side. The right side of the heart pumps to the lungs, then it returns to the left side of the heart, which pumps the blood around your body when it's all oxygenated. These 2 pumps really only work very well when they're contracting in a coordinated fashion. So that's where the electrical system of the heart becomes really important. So the normal electrical rhythm of the heart is a sinus rhythm. It starts with your sinoatrial node, all right? And there are special cells in that part of the heart that fire a periodic electrical signal. And it passes through this very complex electrical pathway with special nerve and heart muscle cells. But basically there's an electromagnetic wave that passes through the heart in terms of milliseconds from this SA node. It passes through the atria first, and then a few milliseconds later passes through the ventricle. So the atria contract a few milliseconds before the ventricles contract, and there's this perfect to and fro movement of the pump. The atria contract and fill the ventricles, and then the ventricles contract and eject all the blood where it's supposed to go. Now, in atrial fibrillation, the problem is you have some pacemaker cells, so-called, that for whatever reason are in the left atrium in particular. These cells can start firing their own electrical signals. They can get noisy enough that they basically start their own sort of drum circle. And if that drum circle gets loud enough, it can interfere with this sinus pathway, all right? So, because it's in the atria, this signal mostly affects the atrium. And it's not a coordinated signal, so the atria start fibrillating, which means just wiggling and not contracting purposefully or effectively. The ventricles are still usually following this sinoatrial signal. So it's like 2 dancers and only one of them knows the beat. The ventricle knows the beat and knows what to do, but the atria are all over the place. So it's a mess. The efficiency of the pump goes down on both sides, both the left and the right side of the pump, by about 20%. That's where your symptoms from atrial fibrillation come from. Your fatigue, your lack of energy, your shortness of breath. And that is devastating in the long term. And it only gets worse because you start exercising less or you can't exercise at all. And in your 60s and 70s and 80s, when you stop exercising, that's when you really start running into trouble. So that initial surgery operation that they did was cut and sew. They basically would cut areas of the heart in open heart surgery and then they would sew it back together. All that did, the cutting and sewing, was create a line of scar tissue. It turned the heart muscle cells, which can conduct electricity across them, into scar tissue cells, which are essentially like rubber. It's insulating. These scar tissue cells will block electricity. It can't get across them. So that's what the scar tissue is useful for. Now, the radiofrequency ablation that is used in surgery now and in catheter ablation creates the same lesions, but just with heat. It burns a thin layer of tissue of the heart muscle cells. We're talking a millimeter wide. And then over time, the body replaces those dead muscle cells with this scar tissue. Now, what that means is the electrical signals that are being generated in this left atrium and in the pulmonary veins that lead into the left atrium can't get out of this box. So it's blocked. We've essentially drawn a corral around that drum circle, and the sinoatrial node and the sinus rhythm system can continue unmolested by that. Sinus rhythm is restored and the efficacy of the pump is restored. In order to do this surgery, requires little incisions on both sides in between the ribs, and we basically make this box around this drum circle area and exclude it, and that gets rid of the AFib. Also, during the surgery, we put a clip on this left atrial appendage. Now, the other problem with atrial fibrillation is because the blood is not moving well in these upper chambers, it stagnates. In particular, in this pocket, this is where your clots form, and that's where your strokes come from in atrial fibrillation. So that's why you have to be on blood thinners, which is another big problem with AFib. While we're in there, we put a clip that goes right across that blind ending pouch and excludes that whole reservoir of clot. So you're no longer at risk for stroke. Now, catheter ablation uses the same concept in terms of trying to burn out this drum circle. I have a little diagram here of the inside of the heart and the outside of the heart. Catheter ablation is endocardial ablation, that means inside the heart. They have very sophisticated sensory systems and mapping systems for the electrical activity in the heart, but they're limited by the size of their catheter. It has to get into your heart. It's a tiny little pinhead. They can only burn limited areas with that catheter. Okay, so very specific, very targeted, but limited in terms of its robustness. Now, surgery, the big downside is it's surgery, but it's minimally invasive with little incisions. But we can get a bigger instrument in there and burn full thickness lesions, more robust lesions, and really exclude that AFib with a really strong scar tissue lesion. So that's why that works really well. Now, here at Saint Alphonsus, we do what's called the hybrid maze. So that is a combination of the surgical maze, which I've described, and a catheter ablation maze. That really gets best of both worlds, right? You have the specificity and direct targeting of the catheter ablation, and then you get the robustness of a surgery without a big open heart procedure, but rather in a minimally invasive way. So I call the surgery part the cake, and the catheter ablation is like the icing on the cake. They can go in usually 6 weeks after our surgical ablation, check our work, make sure there are no gaps in this ablation line, and fill those in with the spot welding catheter. They can also do this years down the road. If for some reason this works for years, but then the AFib comes back, you can get a catheter ablation to find out where the defect is, and it's much more effective. So this isn't done in very many centers across the US. This is one where we have over hundreds and hundreds of patient experiences that have been very positive. We have good results. The success of the hybrid maze is 80 to 90% freedom from AFib for years. And if it does fail years down the road, which AFib does tend to come back sometimes, then a catheter ablation can certainly be likely to take care of that problem. So I think that's really all I wanted to say about the surgical ablation and hybrid maze here at Saint Alphonsus. Look at the rest of the website, and if you want to contact us, please feel free to come in for a consultation.